Roshni, all good?
Yes, sir. Yes, sir. If we
Okay.
could see in the full screen, it would be helpful, sir.
Sure. Is it all right?
Just a minute, sir.
Moving smoothly?
Yes, sir.
Okay.
Perfect, sir. Thank you.
All right.
Roshni, shall we start?
Uh, yes, sir.
Fine.
A very good evening, everyone. A warm welcome to all the esteemed speakers, faculty members, and participants joining us for today's IAIO Expert Insight session on lung cancer on a theme of New Frontiers in Lung Cancer 2025. This is an academic series is an initiative of IAIO aimed at facilitating knowledge exchange and discussion on emerging trends and best practices in oncology. To commence today's session, I now invite Dr. Rajkumar Ramaswamy, sir, our esteemed program director and medical oncology, to set the context and share his introductory remarks. Over to you, sir, please.
Thank you, Roshni, for the nice introduction. Today we are going to, in another 2 hours or so, we are going to unravel the exciting part of treating, as a clinician, treating the lung cancer. As we all know, the epidemic of lung cancer is on us, and we are seeing more and more number of locally advanced lung cancers. As earlier, it was only metastatic lung cancers we are seeing nowadays. We are seeing more and more of, as the incidence and the prevalence increases exponentially, even among the non-smokers. In Indian women, majority of them are non-smokers. They are also reported to have higher incidence of lung cancers. We are seeing more and more of locally advanced, and the challenges are there. Many unmet needs are there. How are you going to address this huge epidemic which is being thrust upon us because of the environmental pollutions, the tobacco smoking, of course, and lung cancer? Still a lot to be done in order to conquer the lung cancers. As we all know that lung cancer, still the 5-year survival is less than 30%. Even in the oncogene driven, if you take the non-onco gene driver, lung cancers is still more grim. The 5-year metastatic survival is less than 15%. As we unravel the whole gamut of lung cancer management, right from the screening towards the newer modalities of treatment in both in the chemotherapy as well as immunotherapy as well as in the ADCs, and many drugs in the pipeline. Is not only is a challenging time to tackle all the lung cancer patients, huge volume of lung cancer patients. It's also more exciting time to be treating a lung cancer because the options are now plenty. Now it's become more like a plethora of options that are available, and which also leads to a lot of dilemmas as well as challenges, which will unravel in another 2 hours or so. So, with this brief introduction, I will now invite, we have a very esteemed panel of speakers, all are very professional and all are leaders in their respective field. So, right now, we are going to invite Dr. Arun Morley, who is the lead consultant, radiologist in Apollo Proton. He is going to talk in another 20 minutes or so, the role of AI in lung cancer screening. This is very important. Lung cancer screening is not implemented universally across the world. Only in USA as well as in China, the lung cancer screening program, that too among the smokers has been found to be successful with the NLST as well as the Nelson trial. But we are saying off late, Arun and Murali also will agree with me, non-smokers also seeing huge incidence of rise in the lung cancers. So these screenings programs have been now directed one and only on smokers with more than 20 or 30 pack, 15 pack years in ex-smokers. So there are a lot of challenges in implementing. India does not have a lung cancer screening program, unlike the breast and cervical. So there's a huge challenges. Even in US, where the lung cancer screening program is reimbursable, comes in the reimbursable, the implementation or acceptance of lung cancer screening programs even in the US is less than 16%. Hardly 16% of the smokers undergo the annual or once in 2 years of their LDCTs. So that's a huge challenge in implementing even in the US the lung cancer screening program. So in another 20 minutes or so, Arun is going to talk on various aspects of role of AI in lung cancer screening. Over to you, Dr. Arun.
A very good evening to one and all. And at the outset, I'd like to thank the organizers for this opportunity to, present my work or my experience in the lung cancer screening. Working in a oncology setup. We do have a screening program in the hospital, not a population screening program, but rather it's more of a program wherein we do a health checkup for patients who come voluntarily, to get themselves checked, especially smokers. Now, like Sir had mentioned, the incidence of lung cancer is on the rise, and lung cancer will always be at the top when it comes to the ranking in terms of mortality and morbidity in men. And of late, we are seeing that there is an rising incidence in women, and also in non-smokers, and we can see that there is a shift in the whole histopathology pattern, because it's moving from the squamous to the adeno, and there is to the small cell thing. So we are seeing a shift in the whole pattern of disease. So I think lung cancer is will be a burden in the future. But why screening? I think various trials and studies have shown that lung cancer screening does, provide a significant survival benefit for at-risk population. Okay. But like any screening programs, there are a lot of limitations when you implement this screening program, especially lung cancer screening into the other population level. And I will just mention a few limitations as such. Okay, and the limitations, and because of these limitations, I think I think the programs are not being be able to uh, put forth in many countries, I think, because of the civil limitations and the equipment and the data needed. Now, of course, AI is one such solution to the varied problems that we expect or we encounter in the lung cancer screening. So let us just touch upon how AI can help us in the lung cancer screening pathway. Of course, everybody is excited about AI now, and
Dr.
what
Murali,
we
Dr. Murali, sorry to interrupt you. We are not
yes,
seeing
sir.
your slides. We are not seeing your slides.
Wait, sir. Wait, sir. Is it visible, sir?
Now it's visible.
Yes, sir. Is it visible, sir? Yes. Now we are seeing the whole hype of AI nowadays, and I think not now, but AI in the future will have a big role, especially in lung cancer screening. Now let us just understand what is lung cancer screening, because we need to understand why and how we can deploy AI in it. And lung cancer screening as of now is primarily for the older population and for people who are heavy smokers. But I think over the period of time, I think the demographics is changing. So therefore, we will be including a lot more of the population in the future, and not enough that we are at a we have a high burden with the existing high risk population, including general population will again, will cause a lot of burden to the existing system. So the modality of choice which is currently at use is CT, and we use what is called the low dose CT. It is the regular CT, except that we tweak a few parameters which make or which reduce the radiation dose to the patient. For example, a normal CT will give you something called a dose of 8 millisievert. 8 millisievert is what it's like a value. So a low dose CT gives you a dose of around 1 to 2 millisievert. So therefore, in a low dose CT, we get around 1/5 of the dose that you will get with a conventional CT. So that's a low dose CT. We have a dose of around 1 to 2 millisievert. What are we looking for? What we are looking for is we look for these nodules or small solid masses. I mean, we are in a screening program, so we want to pick up lesions at an early stage. So we will look at solid lesions or solid nodules, okay, or we look at ground glass density nodules because these are the early precursors of disease. Or we have a mix of both. We call them subsolid nodules, wherein you have solid and ground glass densities. In these observations, nodules or ground glass densities of subsolid nodules, we look at the size of the lesion because it matters, the shape, the margins, and the characteristics, whether it is homogeneous, heterogeneous, and a very, very important aspect is the growth of the lesion between two consecutive scans. Now, based on these factors, we tend to assess the risk and we put them, or we do a risk assessment and we put them in different buckets. To put them in buckets, one such criteria which we use is the ACR or the lung RADS. We have many things like the PanCam model or the British Thoracic Society model. One thing is the lung RADS model, and we classify the diseases in 5 categories and based on the risk for cancer. So let us not delve into this. Let us see how AI will think. Now, because of this low-dose CT, every patient has around 400 and 500 images, the sections 400 to 400, 500 images. So it is a lot of burden on the radiologist, lot of data. The other thing is between radiologists, there is a lot, big variability. One in the measurement, and two in the interpretation. I may say that this has maybe a higher risk, whereas another reader will say that the risk is lower. When I measure, example, there is always the 2 to 3 millimeters. That intervariability. It makes a big difference because anything which grows, let us say, more than 50%, 80%, has a higher risk of malignancy. So again, that variability exists. Then, irrespective of how you follow the algorithms or the which we're supposed to follow, the size, shape, and thing, there is still a lot of false positives and negatives. And one thing which can provide us a solution is AI, and let us see how it can provide us the solutions. So what is AI? Let us not get too much ahead of ourselves, and we are looking at AI. We are still at the let's say the nascent stages when it comes to AI in medical imaging. So AI is nothing but any computer or machine which is able to make human-like decisions. It is able to discover new things, infer and learn from new things, and then in the future, based on what it has learned, it tends to reason out and say, okay, fine, this is X, this is Y, or in this case, it is malignant, or this is benign. So that is what is artificial learning. And two terms, something called machine learning and the deep learning. what happened, these are subsets of artificial intelligence. In this, what we do is actually we feed or we train the computer, the models, with existing data. Let us say we can take data from the NLST study or the Nelson study, the publicly available. We take the CT images, we give it to any model. I can develop my own model, give it that model, train it, and that is called machine learning. Or if I just give it and say you learn by yourself, that is called deep learning. Okay, so this is the basics of crux of AI. So let us see how AI will actually help us in cancer screening. So there are, it's a four-pronged approach. One is in scan optimization and dose reduction. Two in risk stratification and screening, personalization of these screening programs. 3 and 4, which is most important, which I'll be touching upon, is the nodule detection, and also the most important will be the nodule characterization. In terms of risk assessment, age and smoking history alone are not the most important risk factors now. There are other lots of demographic factors which are being taken into account now in terms of emphysema, family history of lung cancer, your the amount of pollution where you stay in, the air quality index. So these, or collecting lot of demographic data is not possible for to do analyze all this and come to to a model by the humans. So AI can do that for us, and various studies, and just there are multiple studies at multiple instances, but I will just quote a few studies, or maybe one or two studies at each point. So this study has taken into account all the demographical models, but what it has done is it has also added the low dose CT. So it combines both the risk parameters or risk factors for a particular patient, takes that into account, takes that input into the observations or CT observations, and gives us a cancer risk score. So various models, when you combine both the demographic data and the CT data, it gives us more confidence in our risk assessment. So that is one in patient risk assessment. Two, very important, is in AI in image optimization. Now we are talking about 1 to 2 millisievert. I think with more robust programs, robust reconstruction kernels using AI, we can reduce the dose. And there are studies which have reduced it from 1 to 2 millisievert to even 0.2 millisievert, which is 1/10 of this. So 1/10 is, it becomes more or less close to maybe more than X-ray. So we can bring it down to that level. That is the future, because if you're going to do it at a mass scale, we need to have a valid reason wherein you are doing it at a less harm. The other is in improving the quality of the images. We have to have images which are sharp and which augment the pathologies and remove artifacts. There is always a lot of noise and artifacts, especially because we are using a low dose. So uh, AI can help us in giving us crisp images or clear images wherein it depicts the nodules clearer and removes all the artifacts. 3, and this is something which will be of use and for everybody, including especially the radiologist, is in the nodule detection. We are looking at 1 mm, 2 mm nodules, and they are very, very subtle. They'll be in the corner or at the apex or near the costophrenic angle. So it is very, very easy to miss such nodules. So what this does, AI can do, is it's a computer. It goes through all these sections without bias. I think it's very, very important. We are at times, we have a lot of biases. We ignore the apices and or the recesses, and maybe at the date during the time of day our concentration varies. So this AI computer programs can actually detect the nodules consistently. I will say, I won't say accurately, but rather consistently, and bring it forth and let us decide, based on our intelligence and our experience, whether it is of significance to risk stratify it and put it at a higher level or not. So this has been there for a long time. We used to call it CAD. It is computer aided detection. Now the softwares and the models algorithms have become more sophisticated, wherein it can differentiate between fibrosis versus a nodule, because irregular nodules can mimic fibrosis. So that is one thing wherein I think AI can help us in nodule detection. Now, the other is not only in nodules. We're not looking at nodules alone. We're looking at something called the subsolid nodules and the ground glass densities. And these very often, we see ground glass densities as a very, very non-specific finding, and we treat them as non-specific findings. So, but whereas in maybe in a screen setup, it will help us. It will mark down all the ground glass density nodules and all these subsolid nodules, because subsolid nodules have the highest risk for malignant transformation. So this will help us pick up, and maybe it help us even give us a chart, and for follow-up, wherein we have a list of all the nodules, ground glass density nodules. Maybe if you have 10 ground glass density nodules, we may not be possible to write it down manually. Maybe AI can do that for us. It will just pick up all the nodules, tell us, okay, fine, X, Y, Z, 1, 2, 3 till 20. Yes. So not only nodules, but also in picking up subsolid and ground glass density nodules. X-rays are not used, but nevertheless, just in case, in the village setups, it's very, very difficult for us to have, especially in our country, equipment or the infrastructure in remote places. I think X-rays also are, AI is being implemented in the X-ray field, also in detecting nodules. More important than picking up nodules, what is of most important is something called the growth. So accurately measuring a nodule between two consecutive scans and then comparing their growth rate is very, very important. It's one of the most important features when we are risk stratifying the observations. And AI can do it without bias, and not only size, but it can measure the area. We do that now. We have come to the level of area measurement. The next thing would be in volume. Volume can be more, because the increase in the distance should be a large before we actually say that it has increased in volume. So I think volume will be more accurate. Now, the other thing which I wanted to say is characterization. When we say characterization, we say, is it are the margins regular, irregular, homogeneous thing on how the surrounding parenchyma is. So AI, with lots of deep learning models, we feed the computer data which has cancer. So it is very aware that, okay, fine, this has this, if A, B, C are present, then it is cancer. So is able to give us more true positive results and reduce the false negatives. Something I want to touch upon now is something called radiomics. I think it's a very interesting field. It is intense. It is data intensive. What it does is it takes that 1 millimeter or 2 millimeter nodule, and it does something called the texture analysis. Now, this is all grayscale. So it takes the pixels. It takes each pixel and then studies the texture of it. Like how we do it for the cloth. It does. It says if a texture is there, maybe it is malignant. So we have to train it. We take all the nodules which are malignant, benign or malignant. Then we train the computer that this texture, if it is there, it is malignant or benign. And this is the most exciting part of AI, wherein because we have a lot of false positives. We have false positives, and we can avoid invasive procedures. Biopsies, lung biopsies are not a simple thing. You are poking in a balloon-like thing. the risk for hemorrhage, the risk for pneumothorax is there, 1 to 2%. So radiomics has a big role, but what happens is it is very, very data intensive. It is thing. So until we get a program which does it automatically, it cannot be deployed at a large scale. And radiomics, this is one of my colleagues' papers, and we've actually tried differentiating nodules, benign versus malignant nodules, and we've had quite a good success in that. So radiomics has a very, very promising role, and AI will make implementation of radiomics into the clinical practice much, much faster and much, robust. Again, we look at multiple factors in looking at nodules and subsolid nodules and classifying them as malignant versus thing. So in summary, the benefits on impact is that you can read more patients, a larger volume of patients, faster. We can do more patients faster, reduce the error rate, error rate, and actually, reduce the number of invasive investigations. And I think that AI is not going to as replace radiologists. I think it's more like a tool, and I think we have to look at AI as like a co-pilot, or just another tool which is going to make life much, much easier for us and for everybody around, and maybe improve clinical care. Thank you.
Thank you very much, Dr. Arun, for this elucidative talk on role of AI in lung cancer screening. Really, lung cancer screening is yet to take off in India in a big way, but population-based lung cancer screening is really neat because the incidence of lung cancer is on the huge rise. And how to determine indeterminate nodule, whether it is benign or malignant. When you go through the literature, it's very mind-boggling, the role of AI is machine learning and deep learning, supervised and unsupervised learnings, and you can even identify the histology, the radiology and pathology. The next speaker is Kunal Sharma, a good friend of me, will be talking on the pathology. There's a huge convergence between radiology and pathology. You can identify even the some of the with the help of an AI, you can identify the mutations also. You can identify the histology. Everything comes under the radiomics. It's a huge, exciting field. Huge convergence between radiology and pathology, and AI is the common denominator converging these two exciting fields to be. Thank you so much, Arun, for these illustrating. Thank you so much. Next, I call upon my good friend, Dr. Kanwal Sharma. He is associated with the Agilus Diagnostics, and he is going to talk on the various biomarkers for the lung cancer. Over to you, Dr. Kunal.
Good evening, sir. Thank you, first of all, to IAIO and Rajkumar sir for having me here. It's always a matter of good fortune to be associated with such an illustrious panel of faculty members, and always very good to see Rajkumar sir. I don't miss an opportunity to do that. So I think I'll just share my screen. Is it visible?
Yeah.
So I think this is a topic that I have given multiple talks on, and it's lung cancer, as we all know, is the poster child for precision oncology, and how genomics has completely changed the way we approach each patient, and how that is different despite the disease being histologically the same. So we all know that lung cancer remains the leading cause of cancer-related deaths in most countries. As per Globocan 2022, we have 2.5 million new cases of lung cancer and 1.8 million deaths from lung cancer. It ranks number 1 in men and number 2 in women. As far as the Indian population goes, we have 5.8% of new lung cancer cases as per the Globocan 2022 data, and 8.2% of lung cancer related deaths. In India, it ranked number 2 in men for cancer incidence. And what we are seeing as a trend is that it's now becoming much more prevalent in younger patients and never smokers, likely due to the rise of oncogenic driver mutations, which stands as the basis of my talk today. Before we embark on the specifics of molecular mutations in lung cancer. Let us just briefly touch upon pathology of lung cancer. Whenever we get, mostly these are the CT guided core biopsies, and when we get them, we usually have a non-small cell lung cancer or a small cell lung cancer. In non-small cell, we have adenocarcinoma, we have squamous cell carcinoma, we also have the large cell neuroendocrine carcinomas, and we do certain IHCs to distinguish between these. We know that TTF and napsin are for adeno, P40, P63, CK5/6 are for squamous, and we have the neuroendocrine markers like synaptochromo, CD56, and INSM1 for neuroendocrine tumors. Sometimes we can get all of them as negative, and that we call as null immunophenotype. So usually the practice is that whenever we have, let's say 4 cores of CT-guided lung biopsy, we divide those cores into two blocks so that two can go straight away for histopath and IHC estimation, and the other two can go for molecular evaluation. Of course, after assessing the tumor content, so that there is no delay and we have reports ready as fast as possible. Adenocarcinoma is further subdivided into lipidic, acinar, papillary, micropapillary, and solid. Solid is the one which is most difficult to distinguish from non-keratinizing squamous cell carcinoma, but we have IHC markers to help us there. And then we have squamous cell carcinomas, which could be keratinizing, non-keratinizing, or basaloid. Neuroendocrine tumors we know can be small cell lung cancer, carcinoid, which could be typical or atypical, and these could be the large cell neuroendocrine carcinomas. The grading is usually done on the basis of mitotic count, but Ki67 also is important in evaluation many a times. As you can see in this case, when you have markedly crushed biopsies and you can't really discern the tumor cell morphology, you can actually you can be mistaken for a high grade small cell carcinoma, and it might just be a low grade neuroendocrine tumor. So with that, let's talk about lung cancer being the poster child of precision oncology and personalized medicine. In the first decade of 21st century, anti-TKIs were tested on lung cancer patients, geftinib and erlotinib. Crizotinib was initially developed as MET inhibitor, but its activity towards ALK kinase led to the use in ALK activating translocations. Further research contributed to identification of newer druggable targets, particularly for adenocarcinoma, and immune checkpoint inhibitors showed spectacular improvement in patients lacking TKI sensitizing mutations. So about 50 to 70% of Asian and 30 to 40% of non-Asian patients with non-squamous NSCLC carry druggable mutations. These could be caused by either gain of function in proto-oncogenes or loss of function mutation in tumor suppressor genes. When we talk about the different mutations, many a times these are still unknown, but based on the type of population, we know that we have more commoner mutations in the Asian population, whereas the Western population shows a slightly different percentage of more commoner mutations. Relationship with smoking, KRAS is usually seen in smokers, adenocarcinomas that happen in smokers. EGFR, ALK, ROS, and RET are usually seen in adenocarcinomas in non-smokers. In Asians, we see a high frequency of EGFR mutation, approximately 40 to 50%, and much lower frequency of KRAS mutation, whereas in the West, it is usually KRAS which is the highest. If you are getting EGFR in squamous cell carcinoma, it is usually a histological misdiagnosis. So make sure that you check your case properly. It might be a mixed histology. There are two major EGFR mutations, infirm deletions of exon 19 present in about 2/3 of cases. These, usually show better response to anti-EGFR, anti-TKIs. And L858R substitution in exon 21, which are usually seen in elderly population. There could be other rarer mutations like exon 18 nucleotide alterations, exon 19 infirm insertions, exon 20 alterations, and exon 21 mutations. Coming to ALK and ROS1, these happen in about 5 to 8% and 1 to 2% of non-squamous NSCLCs. Women and non-smokers like EGFR, no racial differences. And again, these are seen in younger patients. When we are talking about testing, IHC is a very good substitute as far as ALK goes. It's actually a gold standard. But for ROS, the cases which come positive on IHC, they need to be retested again for confirmation, which is usually by FISH or NGS. These are some of our in-house cases showing beautiful positivity for ALK and ROS1. Then you have other mutations like BRAF. It is the easiest to test as all druggable mutations fall in the same hotspot region, that is BRAF V600E, exon 15. 1 to 2% of adenocarcinomas show this mutation, and single agent results in rapid resistance through the MEK pathway. Therefore, we go for a combined treatment. Sometimes we get exon 11 mutations. These are rarely detected and these are usually non-druggable. We also have MET exon 14 skipping mutation seen in adenocarcinomas. These are seen in about 2 to 3% of non-squamous NSCLCs, mostly in the elderly who do not tolerate cytotoxic chemotherapy well. Therefore, if you have a patient above 70 years of age and you have limited tissue, make sure you prioritize MET over some of the others. And we know that crizotinib, capmatinib, and teptotinib can be given in patients who present with MET exon 14 skipping mutations. Then you have RET seen in 1 to 2% of non-squamous NSCLCs. A very novel target is the NTRK, which was first described in 2013 by Vaishnavi et al. And this is almost coming across as a tumor agnostic biomarker these days. We know that this is now tested even in soft tissue sarcomas and in hematological malignancies as well. RNA NGS is the most sensitive for testing, but IHC is also widely available because of faster turnaround time. And the choice of assay again depends upon the resource and institution settings. This is a chart in this slide which tells you, a nice flow chart of how to go about testing for NTRK. You can use IHC as a screening tool, and then you can go for NGS confirmation. And if you have frontline NGS, which comes positive, you can supplement it with your IHC testing to have protein expression. Now, there are different platforms which are available for molecular testing, and many a times people ask which is the platform we should use. So we know that whenever there is high volume of tumor, any method can give you that answer. But in low volume, you need something that amplifies your tumor. So ARMS is a very good modality. When your mutation type is known, you can use a targeted method like we use for small panels. Like, many times we get only EGFR AL cross 1 for testing. So in that, EGFR can be tested through PCR. But if the mutation type is unknown, NGS is a very good modality and the modality of choice. Our costs are also coming down in India quite drastically. So I think NGS is a very good modality. This is a flowchart which all pathologists and clinicians, are aware of who deal with biomarker testing, and it shows you very nicely the different antibodies for different mutations which we detect in lung cancer. Interesting to note would be, of course, the recurrences as far as EGFR mutations go. These are usually the EGFR T790M mutation and how we go about treating these. Now, a question that comes is there a role of mutation testing in early stage lung cancer? Yes, there is a role of mutation testing. We know that there are two very good trials. One is the ADORA trial for osimertinib in EGFR mutation positive early stage lung cancer, and it showed a significantly longer disease-free survival with 80% reduction in risk of disease recurrence or death with osimertinib. And also it showed much lesser CNS involvement, therefore much better increase in CNS disease-free survival. Even for ALK, we had a similar trial called the ALINA trial, in which they show that percentage of patients alive and disease-free at 2 years was 93.8% in the alectinib group versus 63% in the chemotherapy group among patients with stage 2 or 3A disease. Again, cancer spread to the brain was in far fewer people treated with alectinib than those who received chemotherapy. We also have some other tests like KRAS G12C against which FDA has approved sotorasib. And there is a lot of studies which are going on about KEAP1 mutations, which happen through the NRF activation pathway. We do PDL1 testing in lung cancers also. Usually we give the TPS score because we know that most of the survival charts in different studies, they correlated very well with TPS, and lung cancers usually have much lesser inflammation. So TPS gives a far clearer picture about about the eligibility for use of immune checkpoint inhibitors. There are different clones, SP263, SP142, and 22C3. I would just like to tell you one thing, that whenever you're using SP142, the cutoffs are 50% or more for tumor cells and 10% or more for immune cells. So in that, if you have 8% positivity in your tumor cells, it's not positive, it is actually negative. This is our Agilus panel for NSCLC. And I'll just touch upon briefly upon liquid biopsy. We know that liquid biopsy is coming up in a big way in lung cancers. And we know that tumors continuously shed cells in the bloodstream, and these are phagocytosed by macrophages, and then the cell contents are released into the bloodstream. And when that ctDNA is in the bloodstream, we detect that through our liquid biopsy technique. There are certain advantages that liquid biopsy has over solid tumor biopsy. It is less expensive and non-invasive. It captures tumor heterogeneity very well. It is less dependent upon the original tumor site, since tumor from both primary and metastatic sites can be analyzed. Even very few copies of mutant ctDNA are sufficient for analysis. Patients can tolerate serial blood draws, so compliance is very good. It may even allow for evaluation of development of resistance and also for treatment monitoring. And it's a new tool. As I told you, it can even be used for detection of residual disease. But with all technologies, we should always know about their limitations. Patients who are in early stages of lung cancer, they may not be shedding enough ctDNA into their blood, and thus, we might not be able to detect it. Again, presence of normal cell-free DNA can hinder, with the detection for ctDNA. Sensitivity of ctDNA analysis is lower, 60 to 70%. What it means is that absence of mutation finding does not exclude the possibility of a mutation, and detection of mutations at these ultra-sensitive levels also requires extensive validation. So I had some cases to present, but if the time is less, I think I would.
Go ahead, Kunal.
Okay, sir.
Go ahead.
These are just 4 cases that I'll present, and I'll be a little quick, but it'll just show us how, each case needs to be analyzed properly. Our first case is a case of 59-year-old male who presented with pain in the chest and difficulty in breathing since 3 months. Patient had few episodes of hemopsis. Lung mass was seen 4 into 3 centimeters with multiple pleura-based nodules, and it was reported as metastatic adenocarcinoma, likely of colorectal origin. No lesion in colonoscopy or upper GI endoscopy. So this is how the morphology was. And if you see, the cells had abundant intracytoplasmic mucin, and you can see in the lumen, there is a lot of dirty necrosis, which is very typical of colorectal primaries. So I wouldn't blame somebody who had called it as colorectal origin. Also, IHC was very confounding in this case. As you see, 7 and 20 were both positive. In lung, we usually have CK7 positive and CK20 is negative. As we already discussed, the markers for lung adeno are TTF1 and napsin. In this case, both were negative. But we know that there was nothing on colonoscopy. So what are we dealing with? We went ahead and did a few more markers, and in those, CDX2 was positive and SADB2 showed very focal positivity. Molecular profile, HER2, KRAS, and BRAF mutated. EGFR was wild type. Again, something similar to what we see in colorectal primaries. So what was this? So this was actually a case of pulmonary enteric adenocarcinoma. So these are carcinomas we should be aware of, which show GI-like pattern, not just in IHC and morphology, but also sometimes in moleculars. So we should be aware of this entity to not confuse it with mets from a colorectal primary. Case number 2 was of a middle-aged man smoker, presented with persistent cough and dyspnea, had large peripheral lung mass with nodal mets. This was how the morphology looked like. It looked like a poorly differentiated adenocarcinoma. But what caught my eye in this picture is the necrosis. If you can see, there's a lot of necrosis in this slide. And when we did IHC, TTF1 and napsin both were positive. Now, this case had come to me for second opinion, and I was asked by a dear friend oncologist that if it's an adenocarcinoma, go ahead with the molecular testing for lung adenocarcinomas. But because of certain findings, I wanted to evaluate more. And when I put the neuroendocrine markers, all of them were positive. So this was actually a case of large cell neuroendocrine carcinoma. The message I would like to give through this is that sometimes just 2 marker testing on IHC is not enough. We might be mistaking the diagnosis. And in this case, if I had gone ahead with the molecular testing, it would have been actually of not much use for this patient. So this was a large cell neuroendocrine carcinoma. Last 2 cases, 75-year-old male patient, year 2020, presented with dyspnea, cough, chest pain, and episodes of hemopsis. Ex-smoker, stopped 22 years back, smoked approximately 30 pack years. Radiology showed 4 into 3 centimeter mass in left lobe, along with mediastinal node and isolated brain mets. This is how the morphology was. Clear-cut adenocarcinoma. NGS showed exon 19 deletion, started on erlotinib and given SBR. PFS was 11 months. In 2021, progressed with another lung lesion, started on dacometinib. PFS was 4 months. 2022 progressed, developed new lung lesion, started on osimertinib. PFS 9 months. Progressed and now presented with liver and bone and brain metastasis. Liver biopsy showed metastatic adenocarcinoma with positivity for TTF1 and napsin. PDL1 was positive, TPS 5%. Patient was continued on chemo and PEM carbo. The good thing here was that clinician in this case was Vinod Rana sir, and he asked me to do a NGS again. And when we did the NGS again, the primary NGS was not done at our place, it was done somewhere else. we saw that EGFR exon 19 deletion was present, but along with that, there was ROS1 fusion with GOPC. Now, I'll tell you the message in this case. After that, of course, anti-ROS1 treatment was started, and the patient is currently being maintained on that. Now, you see, EGFR and ROS1 are usually mutually exclusive, but this was one case where we saw both being positive. Another thing is when ROS1 is positive, usually the fusion partner is CD74 or EZR. In this case, in the table you see it was GOPC, which is seen usually in glioblastomas and CNS related neoplasms. So ROS1 anyways is seen in only about 1 to 2% of lung cancers. It is mostly seen in non-smokers, but this was a smoker. EGFR and ROS1 mutations are considered to be mutually exclusive. In most cases, the partner for ROS1 fusion is CD74, and GOPC is usually seen in glial neoplasms. Now, you see the important thing here was either it was missed initially or it was a new mutation which developed eventually. So, you have to be open to these kind of aberrancies, and these are mutually exclusive, but you could still see something like this, and this happens day in and day out. I mean, exceptions are known, so we have to be open for these exceptions. Also, whenever you design your lung cancer panel, make sure your depth of sequencing, all those things come into the picture. Now, my last case is an even more interesting one. 70-year-old male patient, left upper lobe lung mass eroding the chest wall, presented with hepatic and bilateral adrenal lesions. Very clear presentation of a lung adenocarcinoma. We know they frequently metastasize to adrenal glands. These are the notes of another friend of mine who had told me this is a metastatic carcinoma lung. Just do an IHC, and if adenocarcinoma, tell me the EGFR status. And if you see on the right side, there were very large suprarenal masses. Okay, much larger actually than the primary tumor. And this is how the tumor looked like. And strangely, this was negative for CK, TTF1, napsin, inhibin, calretin, CD56, chromogranin, most of your primary lung cancer markers, but it came positive for synaptophysin. And it had a lot of necrosis. So was this again a large cell neuroendocrine carcinoma? Something came into my mind, and I did a few more markers like CD34, which was positive. And I also did SAL4 in this case, which was positive, and we did BRG1, and BRG1 showed loss. Now, these are very typical tumors. This was actually a case of SMARCA4 deficient thoracic sarcoma. So that's why we had a loss of BRG1, and these are positive for SAL4. So again, something which looks like lung cancer clinically, even on IHC, there can be overlaps. We should evaluate these cases. And this is from the WHO. You can see that these very frequently metastasize to adrenal glands, and they can many a times present with bulky abdominal disease, thus making determination of primary site very difficult. So with that, I would like to conclude my talk. And this is my team at Agilus COE. Thank you, IAIO and sir, for giving me this opportunity.
Thank you, Kunal. Can you go back to the previous slides of the case 3? This is a very interesting case of a co-mutation, isn't it?
Yes, sir.
Nowadays, more and more we are having a broad based assays, NGS assays, whole genomic assays. How frequently are seeing co-mutations in NGS?
Sir, much more frequently than we thought. What we thought to be mutually exclusive, they are giving us hiccups these days.
We have Dr. Ullas Batra is also with us. Good evening, sir. Hello. Hello, Dr. Ullas Batra.
Sir, good evening, sir.
Good evening, sir. These mutants, they usually will not respond to any kind of combination TK. Even if you combine those TKs, the toxicity is going to be on the higher side. They are the one you need to have chemo. They will respond only to chemotherapy. Am I correct, sir?
So, yes, chemotherapy, yes, they will respond, sir. But again, I think we should look at the VAF and we should look at the copy numbers of ROS and everything. Typically, sir, when EGFR and ROS is, it does coexist in around 2%, I will say, not 2%. I mean, 2% of all EGFRs and all can have. We have had some experience with EGFR and ALK, and we have actually combined osimertinib and alectinib, and which really hasn't really been very, very effective. Cost is an issue in that. But if I have an EGFR,
toxicity is manageable.
Manageable, sir. We just ask them to look at the ECGs and the CBCs very commonly. We ask them to do a QTC interval very properly. The ECG should be done every once in 2 weeks. Do a QTC interval, should respond for some time. So either sequentially or in combination, should try to give them some kind of a target therapy. The issue is if you give only chemotherapy, the survival is going to be only same 10 to 12 months and all. So, I mean, in this particular case, if the patient can take osimertinib plus crizotinib, I'll be absolutely happy with that. Osimertinib plus entrectinib will be toxic. It will be toxic for the cost, finances, and also for the patient. So I think in this particular patient, the patient did not really have brain mets. I would probably give a OC and crizotinib and then do a liquid biopsy, monitor them about how the VAF is coming, and again biopsy them at progression and then see what happens on that, sir.
Okay, fine. We have some questions, interesting questions from the audience. Kunal, you'd like to answer for that?
Sure, sir. I'll just have a look at them.
Okay. Is sputum cytology is a good test to diagnose lung cancer? I don't think so. Sputum has got a very poor sensitivity and in need of a FOB specimens. We need a histology to that. I answered for you. And kindly highlight on tumor markers and IHE and sputum samples. Kunal, for you.
Sir, again, sputum samples we don't usually use for diagnosing. And IHCs, no matter what whether we are talking, let's talk about fluids. We usually get pleural fluids and we make cell blocks out of them. And again, the IHCs that we use are the same. We use TTF1 napsin for adeno, P63, P40, CK5/6 for squamous, and synaptochromo CD56 INSM1 for neuroendocrine. But sputum cytologies we don't usually get for.
Hardly used. We don't rely on them as a diagnostic tool.
Right.
Can these markers be falsely positive in TB, strong oils, and other chronic inflammatory conditions, sir?
Sir, I'm not able to see where to see these questions. If you could just repeat the question for me again.
Chat box only.
Chat box only.
Okay, one second.
They are asking if biomarkers could be false positive.
Can these be false positive in TB?
No.
No. So what we have to understand is if it is a CT guided lung biopsy, TTF1 can be there. It will be there in the normal native lung tissue also. So we have to see histologically first that there is a tumor, and we have to see marker expression in that tumor area, because normal lung tissue will also show positivity for markers. TTF1 will be positive there. If we get squamous epithelium, if it's a bronchial biopsy, sometimes we get squamous epithelium that will show positivity for P63. So the first thing as a pathologist is to identify the tumor area and then see what marker is coming in that area.
Okay, fine. There's a huge convergence of radiology and pathology, and both are being interconnected by AI. So digital pathology, your take on digital pathology, making a diagnosis of biomarkers in addition, how to detect the biomarkers and the response assessments with the help of a digital pathology and AI.
So I think, sir, digital pathology and AI are definitely playing a very big role. Biomarker estimation becomes much more objective with tools like these. For example, if you're talking about PDL1 estimation, you know that this could be subjective, and with the ranges becoming narrower and narrower, if we have AI assisted tools for estimation, it makes our reporting far more objective. So I see these coming in as definitely as a very important assisted tool. I would still say that, as I always tell people, that like when you're flying an aircraft, just because you have an autopilot, that doesn't make the pilot redundant. You will always need a doctor to first make the AI learn what is neoplastic, what is non-neoplastic, what to analyze, what not to analyze. But as an assisted tool, they definitely help our reporting quite a lot.
Some more questions are there, but little off the way. You want to answer that? Off the mark?
I'll do that, sir. I'll do that. We can proceed with the talks. I'll answer them.
Okay. Thank you, Kunal, for this lovely talk. I'll always cherish your talks, and I always like you to visit us in Madurai. I'm waiting for your visit. So
always looking forward, sir. Thank you.
The next talk, I was always looking for that, and that's a more challenging one, because as the incidence of lung cancer is exponentially increasing, more and more locally advanced cases we are seeing in the community, as a community. Unlike Ullas Batra, I'm not in an institution, I'm in a community practice. So I'm seeing so much of challenges and unmet needs in the locally advanced. I'm able to pick out those locally advanced. The NSCLC is more and more often now, but there are challenges on that. How to sequence the treatment, how to go about that. Earlier it was very simple, surgically operable is should be sent for surgery, and operability and resectability also big definitely criteria are coming up in a huge ambiguity in what do you mean by resectability, what are the how to assess those resectability. There's a huge challenges for the community oncologists like me. And then if it is operable, then it's okay, fine. What is an adjuvant treatment? What is an adjuvant? If it is going to be a concurrent adjuvant RT along with chemo, concurrent or sequencing, and you have even you got talk about the neoadjuvant. So many, it's become more like a maze now for me for as a community oncologist. So we are going to listen to Dr. Ullas Batra, right person to unravel those maze and make it more simpler for us. Over to you, sir.
Thank you, sir. Thank you for a very for the invitation, and the last lecture was fantastic. So my congratulations to Dr. Kronal for setting the stage. And it is so nice to see so much good happening in the field of lung cancer and the pathology. Since more is happening in the pathology and the molecular era, more is happening in the clinical era. So that is why the challenges of locally advanced non-small cell lung cancer, and my disclosures here are I'm a medical oncologist, and I'm very happy to see a medical oncology session in locally advanced non-small cell lung cancer, which was once a surgical RT onco domain. It is still one, but then we are also finding our voice into that. And normally I tell them, you decide amongst yourself. We will go ahead and give our immunotherapies and target therapies. We'll find out which one of you guys does surgery or not. So this is like Amitabh Bachchan saying, khush to bahut ho gaye aaj tum. So let's look at the basic scope of the problem. Now, a locally advanced lung cancer can be operable. It can be inoperable. In the operable, it can be upfront resectable. It can be borderline resectable. And inoperable will stay inoperable. Although there's a new data which says that even some N3 disease can be converted to N2. And if you undergo surgery, they will do better. But I will not, it's just in the phase 2 trial. I'll not go for that. After that, upfront resectable, you can go ahead and do surgery first and then give adjuvant chemo, or you can go ahead and give them neoadjuvant chemo and then go ahead and give them, surgery. So either you can go like this, the borderline resectable can go either ways, and the upfront resectable also can go either ways. And these are challenges of just the anatomical pathway of stage 3 lung cancer. To confuse more, you can have oncogene-addicted lung cancer. You can have non-oncogene-addicted lung cancer. What will you do in PDL1 less than 1? What will you do in PDL1 more than 50? We don't know. And when I looked at this, I said, chakkar aa raha hai, I cannot. So I'm sure all the viewers will be having the same. Let me try to make things simple for them. So there are 3 ways in which a resectable lung cancer can be dealt with. Either you do surgery, then you go ahead and do chemotherapy, or you give only 3 cycles of chemotherapy and then do surgery, or you go ahead and give them perioperative, you do give chemo-immuno, you do surgery, and then you give immunotherapy, and that is what the challenges are. So what is the rationale of a neoadjuvant and adjuvant immunotherapy in non-small cell lung cancer? So it is all about the T cells. So let's say in the neoadjuvant one, look at the one which is in the bottom part of your screen. When immunotherapy is given, there is activation of many T cells because the tumor is still in situ. And because there are more T cells, there are more diverse T cells, which will get into more memory T cells, and long-term survival can occur. However, if you have adjuvant immunotherapy, once you have removed the lesion, the T cells are actually not there more. The new antigens are not released into circulation, and fewer and less diverse T cells search for the tumor cells. So scientifically or preclinical rationale basically says that maybe a neoadjuvant immunotherapy might be better. Now, from a rationale, did we have a phase 1 or a preclinical study? Yes, we had, not in lung cancer, but in melanoma, in which they found out the T cell expansion. So what they did was small study, around 30 patients were there. What they said was in melanoma, they found out that they found out and analyzed T cells, and they basically found out that when you give them immunotherapy and then do surgery, the T cell expansion is much more than what you see when if they were given in the adjuvant ones. So more neoantigens are released in the neoadjuvant, more T cells are there, more T cells get expanded, and that is why probably this is the result which we get, not again in lung, but in the melanoma, where again they compared only adjuvant group or a perioperative neoadjuvant to adjuvant group, and they found out that the neoadjuvant adjuvant was far more superior to the adjuvant group. So that was about the preclinical rationale. Now let's look at what is the evidence of neoadjuvant chemoimmunotherapy. So around 7 to 8 studies have been done, which have by and large taken around 60 to 70% of stage 3 lung cancer patients, which they had. A good point is around 80% of people have actually undergone surgery, which is not bad. I will tell you later. And the pathological CR rate is some to the tune of around 20 to 22%, which is only 4% with only chemotherapy. So remember, in our time when we used to give chemotherapy, 4%, 2% chances of PCR with neoadjuvant chemotherapy. But now this rate is around 24%, which basically comes over there. And this PCR actually turns up into a huge EFS advantage. And please remember these EFS HR numbers, 0.63, 0.59, 0.56, so somewhere around 0.63 is what we usually get. And more than 3 years of EFS is what you get if you go ahead and give the neoadjuvant chemoimmunotherapy. And the overall survival, this is the overall survival. These are two publications which have been published where you go ahead and give them either neoadjuvant chemotherapy alone or a perioperative chemotherapy, and look at the 5-year survivals of 65%, 53%, and 65% versus 55% at a 5-year rate. And these trials had 70% of people who were actually having a stage 3 lung cancer. So, and look at the tail. I mean, just look at after 71 to 65, only 6% drop was there. So there are people who are actually becoming long-term survivors, even in a stage 3, stage 2, stage 1 lung cancer. Now, this is absolutely fantastic. So, neoadjuvant chemoimmunotherapy increases the PCR, increases the EFS, increases the OFS. But there are some valid concerns of, criticisms of neoadjuvant immunotherapy. That is, I told you only 80% of the people actually go ahead and do surgeries. So what about people, 20% of people actually do not undergo surgery in this. So these are the role of missed surgeries which are there. Now, this surgery is around 81 to 89% people will undergo surgery, and 20% of people will actually not undergo surgery, which is there. But is it same only with neoadjuvant chemoimmuno? No. If you look at the Pacific 2 or the Checkmate 73L trial, people who started with CTRT at that time also around 10 to 15% actually progress. So the biology of the disease actually is bad in that. And even with immunotherapy, if you're saying the adjuvant immunotherapy, if you do surgery, 6 to 7% of people actually develop the progressive disease to completion of adjuvant chemotherapy. So there will always be those 10 to 15% of people who will progress during the CTRT or during the chemoimmunotherapy, which is actually not a bad thing, because then you're actually salvaging them better and you're not exposing them to surgery. Again, so let's say people who cannot go to surgery in the Checkmate 816 trial, they actually compared, okay, fine, you give to the 20% of people, they saw, okay, fine, 20% of people did not undergo surgery in the chemotherapy, in the chemoimmuno. Similar people did not undergo surgery. What happened to those people? Again, these people did much better than the people who did not get immunotherapy. So you give them chemoimmunotherapy, even if they don't go to surgery, these people do much more better, whether they take radiotherapy or more immunotherapies, that is another issue. Now, some people say whether the surgery will get more difficult. I was in the tumor board discussion on that day, and my surgeon told me there is so much of fibrosis which happens after the neoadjuvant chemoimmunotherapy, which is absolutely right. But the complication rates were not increased. So if you look at this over here, the p-value between the surgery was absolutely okay. So there is no increasing difficulty. Yes, there is fibrosis, but I'm sure our surgeons can deal with this fibrosis very, very easy. So surgical complications are not increased after the neoadjuvant chemoimmuno. The safety profile for this is absolutely manageable. That is also not a big concern at all. Now, what about the PDL1 negative people? In the PDL1 negative, so the more PDL1 you have, the more stage you have, the more benefit will come. But if you have a pooled meta-analysis of this, it also showed that there is a 0.74 HR. And I want you to remember these two HRs which was there. One was the EFS of 0.63 and one was the PDL1 negative HR of 0.74. Just remember these two numbers. I'm going to come up over there. Now, this basically begs the question, if the results of neoadjuvant and perioperative are same, do we need the adjuvant component of the perioperative chemotherapy? And that is one question which is there. Just look at this, checkmate 816, 72%, 71%, 65%, 68%, by and large equal. So to me, 3 cycles of checkmate 816 is absolutely okay in people who achieve a PCR. Where will I give people who do not a more perioperative regimen if they are PDL1 negative, if they did not achieve a pathological CR, or if somebody has done a ctDNA and then they have not achieved a ctDNA clearance, I will give. But somebody who has done a ctDNA clearance or a PCR, I will not go ahead and give them any adjuvant chemotherapy. For me, checkmate 816 trial is a game changer. I would be very happy actually in going ahead and giving them just 3 cycles of chemoimmuno and just following them up with this. I will not really pressurize the patient to go ahead and give them 1 full year of immunotherapy. Let's compare this strategy with the adjuvant immunotherapy strategy. And there are 3 trials basic. So we said borderline resectable and resectable. You have neoadjuvant and you have adjuvant. A lot of surgeons will say, and I hope there are surgeons here, we will go and resect it. We will see what happens. So 3 major trials, IM Power, BR31, Keynote 91. And these 3 trials are basically shown. Just remember the EFS which I showed you. How much was that? 0.58, 0.63, 0.40. How much is the endpoint over here? HR of 0.89, 0.76. Look at the graphs, I mean, they're by and large just superimposing on each other. And this is not only it. You look at I showed the 5-year survival outcomes with checkmate 816 and keynote 671. That was a perioperative. And just look at the overall survival advantage. This is the OS in the ITT population. There is absolutely no difference in the intention to treat population. The only difference comes if you have a PDL1 more than 50%. Again, just look at these 2 trials. This is the 5-year OS of adjuvant. This is the 5-year OS of neoadjuvant and perioperative one. What about the PDL1 status? PDL1 negative, absolutely no role in giving in adjuvant setting. And even if you have a PDL1 1 to 49, remember the trial has been, in some things, it has been approved for more than 1%. But that benefit is basically being driven actually by more than 50%. If you have PDL1 1 to 49%, it does not really benefit the adjuvant atezolizumab trial. This is the FDA approval. EMA is more sensible. They've approved it only for more than 50% of the patients actually. So in locally advanced lung cancer, to me, a perioperative and neoadjuvant is better than adjuvant immunotherapy. PCR is highly predictive of overall survival. A 5-year of NACT-IO alone is similar to a perioperative regimen, may be ideal for an LMIC. I may consider for a longer duration of immunotherapy in people who do not achieve a PCR or a PDL1 negative. Post-operative surgical complications are not increased with perioperative immunotherapy. And 20% of people, this we should tell the patient, they are not amenable to surgery after the NACT-IO approach, which may not be a bad idea actually. So the challenge is absolutely accepted in this case. That is all about the resectable or borderline resectable. Now let's look at the CTRT components, that is the unresectable. So again, one more thing is this resectability and unresectability should be discussed in a tumor board prior to giving them chemoimmunotherapy. We cannot be asking surgeons and they say you go ahead and give 3 cycles of chemo and then I will decide. That doesn't happen. The resectability has to be discussed upfront. So if you are unresectable because of a T4 disease or a pulmonary artery involvement or an N3, I have 4 questions. What is the standard of care? Any role of concurrent immunotherapy? If immunotherapy can be given earlier in neoadjuvant, can we give concurrent RT along with immunotherapy? Any role of IO maintenance after sequential RT? Lot of people in India give sequential CT-RT in a government sector because they don't get dates, and in a private sector because you want to start the patient, the fields are too high. And what about the oncogene addicted lung cancer? So these are challenges that I feel are there. So what is standard of care? Standard of care is specific, no doubt. CTRT followed by immunotherapy with durvalumab alone. We basically have achieved a median overall survival of a 42 versus 33.4%. So this is absolutely huge. This is the standard of care. Now, if durvalumab is so good, can we put durvalumab in addition? So this was a trial which basically says we'll give chemo radiation and we will add radiotherapy along with durvalumab to start with, and then we'll give consolidation immunotherapy. So get immunotherapy as early as possible. This data was just presented last 2 weeks back at ESMO, and this trial showed exactly the thing which we were thinking. There is no role of concurrent radiotherapy and immunotherapy. Is this the only trial? No. You have had Pacific 2 trials where again durvalumab was given along with that, and the trial was by and large negative. Nivolumab, such a good drug in the neoadjuvant setting, absolutely. If you give it concurrently with radiation, absolutely no role. Even the ISABR, you give SABR and then go ahead and give them immunotherapy or along with that, SABR plus pembrolizumab, it does not really work. So in cases of immunotherapy and radiotherapy, timing makes a difference. You do not in lung cancer give immunotherapy along with radiotherapy. That is important. So we spoke about CTRT followed by consolidation. Yes. CTRT along with IO? No. What about if you give sequential RT-CT, sequential chemo, and then you give RT and then you give durvalumab? So this was a Pacific 5 trial design, which basically said that you give sequential CT-RT and then you give durva. And again, in this, durva was given for till progressive disease. What we basically found out at that trial was that even the sequential CT-RT is absolutely okay. So if you go ahead and give 2 cycles of chemotherapy, then you give radiotherapy, chemotherapy, and then you give durvalumab, that is absolutely all right. And these were the graph which was presented that the concurrent is better, but even in sequential, durvalumab can be given over there. So the last one about the oncogene addicted lung cancer. So please go ahead and do an NGS as Kunal was telling. Please go ahead and do NGS in all the patients. And this trial said that if you have after CTRT, if you have an oncogene addicted, what will you do? Points to note, osimertinib was given till progression over here. So according to them, stage 3 lung cancer is a systemic disease. If you give it in ADAURA, you give it for 3 years. Pacific, 1 year. But in osimertinib, LAURA actually is for 3 years. That is the point to remember over there. Again, osimertinib was given to people who had progressed in the people who did not receive. And both sequential concurrent CT scan were allowed over here. And this is the PFS curves which you see over there. And there's so much graph that you can actually fly an aeroplane between the two. And this PFS curve showed that every subgroup actually benefits from addition of osimertinib. And the drug is non-toxic. Osimertinib ILD rates were not very high. This is immature data, but you look at that at 4 years, 70% of people are alive in the osimertinib versus 52%. 18% advantage at 4 years is absolutely fantastic. Living without disease is also very, very good. So my last slide, I said challenges in unresectable lung cancer. What is the standard of care? CTRT followed by immunotherapy for 1 year is the standard of care. Any role of concurrent RT with immunotherapy? No, there is no role of that. Timing matters. Any role of IO maintenance after sequential CTRT? Yes, we are going to go ahead and you can give durvalumab after that. What about EGFR addicted non-small cell lung cancer? By and large, it is osimertinib. If it is, so do an NGS. That's the most important thing. Do an NGS in all stages, whether it is 1, 2, 3, 4. Please do an NGS. If a patient has got EGFR mutant or any oncogene-addicted lung cancer, don't go ahead and give them immunotherapy. If they are EGFR addicted, please go ahead and give them osimertinib. For the other biomarker, I'm sure somebody will ask me that what happens if it's a ROS. I don't know. I don't know. That's the answer. I don't know what is to do. What I know is I will not give them immunotherapy. I will probably keep them under observation and then follow it up over there. But these are just some challenges that we have navigated and miles to go before we sleep, because of 5 years survival of 60% is not enough with us. We want 80%, 90% survival with that. With this, thank you. And I'll be happy to take any questions if there are any.
Thank you so much, Dr. Ulapka. This is a very nice one. More and more we are seeing these PDL1 negative, non-oncogene addicted cases. All the markers are being negative with PDL1 also not showing less than 1% expression. Some of the trials have shown that the immunotherapy works in the presence of only more than PDL1 expression, more than 50%. Example, the atezolizumab, but some of them like durvalumab works even in 1 to 49%. So that's immunotherapy depends upon the PDL1 expression in the case of a locally advanced one. Absolutely, these PDL1s more than 1% positivity do help us in choosing the right IOs, or irrespective of the PDL1. Some of the medical oncologists do argue for that. Irrespective of the lung cancer, the locally advanced management, irrespective of the thing, you have to choose your IOs.
So, PDL1 is an imperfect biomarker, but that's all that we have. So what happens is the tone of my voice changes. If I have a PDL1 positive, I will not deny anybody immunotherapy if you are PDL1 negative, but I will not push somebody for immunotherapy if you are PDL1 negative. I'll tell them they close, the HR is 0.8, 0.89. If it is more than 50%, I will say, please go ahead and take it. So I will not deny anybody with a PDL1 negative tumor to get immunotherapy, but I will also, not really push them for that. And again, sir, we just had a clinical trial. We had a PDL1 30% in one specimen, and the same specimen was sent to central lab for review. There is zero. So there is a lot of, 22C3, sp263, intra-tumor heterogeneity, inter-tumor heterogeneity, a lot of things are there. So I will not deny anybody, but I will tell them the evidence is not that strong. The evidence is far more stronger if you have PD1 more than 50%. In adjuvant setting, I will not really offer them, because in adjuvant setting, you have got the entire tumor out of that, and then you are doing a PD1 testing on that. So in an adjuvant setting, things are different. The new adjuvant setting, I'm okay to give, but tone of the voice changes.
In real world practice, also we got bound of fingers using IOs in the PDL1 negative subsets. That's not what it's much.
And in the metastatic setting, I am now trying to shift to move away from single agent pembro. I'm thinking in terms of a Nivo EP if the patient is fit. I would rather give that. Sir.
People combine the immuno in the neoadjuvant setting along with your biomarker-driven strategy also. They also found to be useful like osimertinib plus IOs in the neoadjuvant setting. What take on that? It enhances the
Neo-ADAURA trial was there, sir.
PCR rates.
Correct. So in the Neo-ADAURA trial was there. For the lack of time, I didn't speak about that. So Neo-ADAURA has shown a 24% MPR. What I would like to tell you is, sir, neoadjuvant chemotherapy is not similar to neoadjuvant immunotherapy, is not similar to neoadjuvant TKIs. So the PCR that you will get with neoadjuvant immunotherapies are much more higher. A neoadjuvant TKI will still, the TKIs will act only till the time you give the TKI. After that, it will stop. So what my take is, if there's a patient who has got a multi-station N2 or a T3, T4 lesion in which you are thinking in terms of a pneumonectomy and you want to go ahead and give them a neoadjuvant chemotherapy, I will go ahead and give them Neo-ADAURA OC plus chemo combination and then continue with osimertinib later on over there, sir. But if I have a stage 2 disease, with a single lymph node, I'll tell my surgeon, please go ahead and resect it, and I'll give them ADAURA kind of a treatment later on.
Is it possible to make the unresectable to a resectable one?
No, sir. There's a trial which has gone out which said N3 disease. Let's downstage them to N2 and N1 and then see whether we give surgeon RT. But no, a neoadjuvant immunochemotherapy is not going to make an unresectable disease resectable as of now. Let us not even go over there. So this decision has to be discussed in the tumor board upfront, sir.
Is it a role for any neoadjuvant chemo, RT plus immuno?
Neoadjuvant chemo?
RT plus immuno? RT plus
So
chemo plus
there
immuno.
are trials going on, sir, which are doing that. But again, sir, RT and neo, so it will cause a lot of fibrosis. So I think the surgeons are happy. We are giving them the same results for neoadjuvant chemo. They don't really want another complication of RT, because after RT, the fibrosis becomes so much that they will not be able to operate. So they're happy with us. We are happy with them. Radiation oncologists, we give them the unresectable ones and then see from there, sir.
Dr. Rajan Yadav and Dr. Prasanna, both medical oncologists there. Do you have any queries to ask Dr. Patra? Dr. Rajan Yadav, Dr. Prasanna?
So just that I am very enthralled by the slides that you made and the popular culture references, and the doyen of the field has spoken. I don't think there is much I can speak beyond that.
Thank you for that. But my problem is, I think people call me only for my slides. They don't call me for my knowledge anymore now.
No.
Ask for queries and okay,
I'm
Dr. Prasanna.
trying to get as close to those slides as possible.
You are doing much better than that, I'm sure.
Dr. Prasanna, you have any queries to ask Dr. Patra?
No, it's good. Great insights. Thank you.
Thank you.
Thank you, Dr.
Thank you,
Patra. And I'll be very happy to host you in Madurai. And
you have not yet invited me, sir.
Yes, I will definitely do it. Definitely.
Sure.
Thank you so much.
Sure, sir.
Next is Dr. Prasanna. Are you there?
Yeah. So good evening, everyone.
Talking on the ABCs of ADC. Go ahead, Dr. Prasanna.
Good evening, everyone. At the outset, I'd like to thank Dr. Rajkumar sir and IAIO for giving this opportunity. So the topic is ABCs of ADC. Let me share my slides.
It's visible.
So is it visible and audible?
Yeah. Visible and audible.
Yeah. Thank you. So the topic would be ABC of ADC in lung cancer. So I'll be limiting to the newer updated versions of ADC. So let us start from the timeline of how they coined the word of antibody drug conjugate. So it was in early as 1910, the Paul Ehrlich was proposed a concept of a magic bullet. And after nearly 1 century of latency that came in 2000, we had the first ADC drug developed, that is gemtuzumab oxazomicin, which was typically approved for ALL. And then came a wide variety of influx of ADCs, especially more than 100 ADCs are in the pipeline in different stages of clinical research across the solid tumors and also hematological malignancies. So this is the basic structure of any antibody drug conjugate. They have typical key functions. I will call it as 4 components. One is it needs a target antigen to recognize the target on the cancer cells. And we need an antibody, that is a guidance system for the cytotoxic drugs to bind with the target. And we have a linker which acts as a bridge between the antibody and the drugs. And this also can control the release of the drugs inside the cancer cells. And at last, this is the more precise delivery of the cytotoxic drug into the interstitial cells of the cancer microenvironment. And hence, the cytotoxic drug, we should have a warhead for destroying cancer cells. So this is a various mechanism of action of any antibody drug conjugate. We have, as I said, we have an antibody, we have a linker and a cytotoxic payload, and it typically acts on the cancer cells and also has some bystander effects and also can produce apoptosis of the cancer cells. And it also has, beside of the main action, mechanism of action, it also has several sideline actions, like it activates the complement-dependent cytotoxicity and also the antibody-dependent cellular cytotoxicity, that is ADCC, and what we call it as ADCP, that is antibody-dependent cellular phagocytosis. So these are all other mechanism of action of ADC. And this is the main mechanism of action. So what a ADC does is, for target-mediated hypothesis, we call it. The target is being a target antigen is being identified by the antibody, so it makes an antigen-antibody complex, and it internalizes and it forms an endosome, and it's recycling into the plasma, and it has the lysosomal effect, the proteolytic activity, and the payload is being released into the tumor interstitium, and it acts on the cellular pathways. So this is the basic mechanism of action of any antibody drug conjugate. So we classify ADCs according to the generation of drugs. The first generation ADC was mouse or chimeric humanized antibodies, where the linkers were just unstable and the payloads were low potent, like doxorubicin or calciamycin. And there are various disadvantages of first generation ADCs, like heterogeneity, a narrow therapeutic index, and off-target toxicity, high immunogenicity, and slowly things evolved. And we had a second generation ADC similar to adotrastuzumab vedotin or TDM1 and brentuximab vedotin, especially with the humanized antibodies. So they also had some disadvantages, especially the heterogeneity and also the fast clearance of high DARs, and also off-target toxicity as a premature drug loss, and they eventually developed drug resistance. So now we are living in an era of third generation ADC, which is fully humanized monoclonal antibodies, and they have a stable linker in circulation, and so that they can precisely control the drug delivery into the tumor sites, especially the tumor interstitium. And the typical payloads were highly potent, especially the novel payloads like immunomodulators has been added to it. And also the favorite examples would be polatuzumab, where we use for DLBCL, and also the TDXT or FAM trastuzumab deruxtecan. So the advantages of third generation ADC are high efficacy in cancer cells with low antigen, and more potent payload and less off-target toxicity. But there are also various disadvantages, especially the coming to the drug resistance, and also the highly potent payload can have a cytotoxic toxicity. So these are all the major ADCs that is in development in non-small cell lung cancer. So we can categorize into three varieties. One is the biomarker selected, that is the HER2 overexpressing non-small cell lung cancers. We do have HER2 DXD, that is TDXD. And the next is the biomarker non-selected patients. We have a TROP2 targeted ADC, and we have a HER3 targeted ADC. And in protein selected population, we do have c-MET activated non-small cell lung cancer targeted ADC. So let's go one by one. So first, let's see HER2 overexpressed antibody drug conjugate. So the first generation ADC, as we are talking about in HER2, we have a TDM1, which was first probably the preliminary used in lung cancer, but probably the phase 3 trials have shown very less benefit, and then people shifted to the TDXD, that is the next generation ADC or TDXD. So it has a typical topoisomerase 1 inhibitor payload and more of drug to antibody ratio, that is DAR is 8:1, and it has a tumor selective cleavable linker, and also it has a potential activity of bystander effect. So this is the Destiny Lung-1 trial, which popularized the HER2 overexpressing non-small cell lung cancer usage of TDXD. And this is the very encouraging data that has been presented with median overall survival of 11.3 months in Destiny Cohort 1 in HER2 overexpressing non-small cell lung cancer. And with the dosage of 5.4 milligram per kilogram in HER2 3+ patients, we have the median duration of response is nearly 7 months, and overall response rate was nearly 53%. And as of April 5th, 2024, TDXD received accelerated approval for metastatic HER2 positive, that is IHC 3+ solid tumors, as a part of the pan-tumor trial, and with prior systemic treatment and no satisfactory alternative treatment options. So the median PFS in this category was nearly 6.7 months. So it has certain prominent side effect also. So probably at least 25% of patients can have a risk of interstitial lung disease. So patient selection is more important. So patient is already compromised COPD or lung function has to be carefully selected for TDXT usage, and majority of this ILD or grade 1 and grade 2, and the median time of onset of ILD is 141 days, and the median duration is 43 days, and it typically responds to the glucocorticoids. So, and then came the Destiny Lung 4, that is, it compares the TDXT usage in the first line with HER2-positive non-small cell lung cancer versus the standard of care. So whatever may be the standard of care, whether it's platinum-based chemotherapy with or without immunotherapy. So this has been ongoing trial. So probably the results would come in the later side. So the next biomarker non-selected ADC, we do have HER3 receptor-based targets. So let's go into that. So this is the famous HERTHENA Lung 2 trial, which used, that is patritumab deruxtecan, that is HER3-DXd. So this is a heavily pre-treated patients with EGFR TKI. This is typically in an EGFR activated mutation, either exon 19 deletion or L85R mutation. So the disease progresses after 2 lines of even third generation TKI. So these patients were randomized into the chemotherapy arm and also the HER3-DXd arm. So the results were again encouraging in HERTHENA Lung 2. The median overall survival was 16 months and median PFS was 6 months. So the next drug acts against the HER3 is izabrand, that is izanolone brentican. So this is again the drug in pipeline. So, and also this potential advantage is high DAR, that is a drug antibody response ratio, and the enhanced bystander effect also adds to the benefit. So when it comes to the treatment naive combo plus osimertinib with the overall response rate of nearly 100%, and the 12 months PFS rate was 92%, and post TKI sitting, the PFS increases in 12.5 months, and post the third generation TKI monotherapy was the PFS of 12.5 months. Very encouraging results in izabrand. So the next would be a TROP2 mediated ADC. So we have 3 typical drugs. The famous one is datopotamab deruxtecan. This is an anti-TROP2 IG1 monoclonal antibody, and this is has a cleavable linker, and the payload is typically a deruxtecan derivative similar to TDXT. And the next one would be saxatuzumab govitecan. This acts on the IgG1 kappa, and the linker is again cleavable, and it has a typical irinotecan metabolite, that is S138 payload, with the more active DAR is nearly 8. And the next would be the saxatuzumab tirumotecan, and this is again having a cleavable linker with a payload of belotecan derivative and nearly the 7.4 DAR. So this is the Dato-DXd, that is the Tropion Lung 5 and the phase 3 Tropion Lung 1 trial. So all these patients have a typical actionable genomic alterations, and they have completed 1 or more lines of targeted therapy and heavily pre-exposed to cytotoxic drugs. And these patients, the poor category patients, are exposed to the Dato-DXd of 6 milligram per kilogram every 3 weeks. And the results again were encouraging with median PFS of 5.8 months or 6 months and median overall survival of 15.6 months. And the patients with prior osimertinib also responded well with the median overall survival of 14.7 months. And when it comes to safety, it is just stomatitis, alopecia, nausea, fatigue, very minor side effects, especially adverse events. And the median Dato duration was 6.1 months in overall patient population. So again, the results are encouraging for Dato, and probably we can soon come into Indian market. The next drug would be the saxatuzumab tirumotecan. Again, these are Trophus not for trial. And as I said, heavily pre-treated patients with multiple EGFR mutation targeted therapies, and also pre-treated with palliative chemotherapies, first line and second line drugs, and were exposed. And probably the results are encouraging with overall response rate of 60% in EGFR mutant patients So the phase 3 trial would be ongoing for this drug. So the next category of drugs, what we see in ADC is the MET overexpressing or MET protein expressing drugs. For example, we have telisotuzumab vedotin. So this is the Teliso-V, what we call. So it has the same base monoclonal antibody, but the payload is completely different. It has a microtubule inhibitor similar to polatuzumab, and we have a c-MET target clinical validation. So we have a phase 3 clinical trial for the MET targeted activity, and this is the results. So the durable clinical rate was nearly 54%, and the median duration of response is 8 months, and median PFS is 6.8 months, and the progression-free percentage is nearly at 12 months is 25%. So again, the results were very much encouraging. So we have a separate class of drugs now being tried as a conceptual evidence for lung cancer. We have bispecific antibody drug conjugates, that is bispecific ADC. So it combines the activity of a monoclonal antibody and also the antibody drug conjugate. It improves the selectivity of action, and it overcomes probably the resistance, and it has also the obligate mechanism of action. Probably it hijacks the intracellular transport and lysosomal internalization, and probably the more of a cell kill. So probably we might see a synergistic bispecific ADC in the future. So one of these kind in a phase 1 trial would be the IZA-BREN, that is the EGFR activity and HER3 target. So this is again the first phase 3 trial versus osimertinib is now being launched in China. So probably in the next few years, this drug might see the limelight. And thank you so much for your patient listening.
Thank you, Prasanna, for the nice talk. And more and more we do NGS for the upfront NGS, and more we identify the targets. We are seeing rising numbers of HER2 positivity also. We are treated with H2 positivity also. The question that is now becomes a plenty, it's become a cocktail of drugs available in a metastatic setting. So it becomes more like choosing the right one. And more important pertinent question will be a sequence. How to sequence in a metastatic, whether it is immunotherapies or targeted agents. And then if they are progressing down the line, then right now the recommendation of the third line and down the line progressing after the standard of care of osimertinib, then ADCs forms the major thing. What happens after the ADC? There's a big question mark. So thank you so much, Prasanna, for this nice talk on ADCs are fine. Now we go to the next talk. Dr. Rajan Yadav.
Sir, am I audible? Are the slides visible?
Yes.
So thank you so much, Talaivar, for having me here. I'm a undergraduate of Kilpauk Medical College. So it's like revisiting home. And thank you for giving me the responsibility to discuss the role of immunotherapy in non-oncogene addicted metastatic non-small cell lung cancer. So immunotherapy is not a recent development. It was as early as 1890s that a bone tumor surgeon from Memorial Sloan Kettering called William Cooley's described something called Cooley's toxin. So here in the background, you see a picture of him with his daughter, Helen Cooley, who went on to find the National Cancer Institute in New York. And they still invite a lot of.
I'm able to see Dr. Cooley, but I'm not able to see Dr. Rajan Yadav.
Oh, sir. I think there's a connection problem. Yeah, there you go, sir. I think, yeah. Okay, sir. So, yes. So we celebrate 50 years of Talaivar and 135 years of Cooley's serum this year. And this is a tribute to both of them. So disclaimer, I have liberally borrowed few slides from CCO, and I have a penchant for theatrics, as you'll realize as I go along. I'm a fan of non-linear plots. So the data that I'll be presenting would be in a scratchy manner, a trial here, trial there, and then in the end, I'll try to make some sense out of it. So I'm a big fan of non-linear plots. And the journey began in 1891 with William Cooley. First use of bacterial injections was described as Cooley's toxin, and then in 1998, the checkpoint pathways were recognized. In between, a lot happened. I'll visit that. We all know pre-immunotherapy era, non-oncogene driven things were a sobering reality with 5 years survival touching as low as 5%. And there was a lack of personalized treatment for 75% of NSCLC patients. Gefitinib was doing rounds. It came in as early as 2005. It went in, came out. The truth is that there was something for the targeted mutations, but for non-oncogene driver mutation, NSCLC, they were destiny's neglected child. Cut to the Cold War. Rivalry, for a better word, is good, especially for science. So in the Cold War era, 30 years, the advancement in science was way more than 2000 years preceding it and 50 years after it. Same was seen in the movie Rush when James Hunt and Nicholas Laura pushed each other. You will be wondering why I'm talking all that. So people always think of them as rivals, but they are truly each other's fans. This is what happened when Oregnon and Medrex pushed each other in this pathway. Schering-Plough was bought by Oregnon, and Merck finally bought all of them, and Bristol Myers Squibb bought Medrex. In between, there was, I think, I'm not able to move the slides. Yeah, in between, the Shanghai Junshi Biosciences were looking at everything. So the mechanisms and biomarkers have been discussed in details. I won't revisit them, but truly the modern immunotherapy can be attributed to these two greats, James P. Allison and Sakyu Honyo. Professor Allison published a work in 1995 that they demonstrated that by blocking CTLA-4 with antibodies led to enhanced T-cell activation and tumor rejection in mice. And no doubt, the golden boy smiled on them. They got a Nobel Prize in 2018. Coming to the first superstar, pembrolizumab, PD-1 checkpoint was discovered by Sakyu Honyo and later Oregnon with the help with Gregory Carvan, Hans Sven, Eneman, and Gradus Doulos developed what we today know as pembrolizumab. It was the first drug to get a tumor agnostic approval at the FDA, and it was a historic moment. Nivolumab followed suit, and there was a race. So this is a brief history of how history of modern immunotherapy in lung cancer. The two people who were primarily responsible for human trials were Suzanne Lewis. The truth is that she thought bringing immunotherapy in lung cancer is a crazy idea. She thought lung cancers are too cold for that and basically wanted this to go the melanoma pathway. But Julie Brammer did us a big favor by doing the Keynote 24 trial. And the therapy decisions are made based on disease stage, histology, presence of targetable mutations, and PDL1 expression, which we'll be concentrating on this in this slide. So I'll start with the climax first. If there's PDL1 greater than 50%, you give immune checkpoint inhibitor, single line is good enough. You avoid chemotherapy toxicity. 1 to 49%, we need an immune checkpoint inhibitor along with a chemotherapy backbone, and PDL1 less than 1 is a different game altogether. So single agent immune checkpoint inhibitors in first line setting, as I described, Keynote 24 was the first trial. It compared platinum-based doublet with pembrolizumab. And as we see, the Kaplan-Meier curves are as separate as possible. It showed a median OS of 26.3 versus a 13.4 month when compared to chemotherapy overall. And 5-year overall survival was 31.9%. This was unheard of in pre-immunotherapy eras any which ways. And overall response rates were 45%. Again, Keynote 4.2 was done, taking an inspiration from Keynote 2.4, and they did it for all comers. They also discovered the same thing, that in clinical practice, monotherapy is preferred only and only if TPS is greater than 50%. So the biomarkers which showed benefit were tumor mutational burdens greater than 175, and a TPS of greater than 50%, where a single agent immune checkpoint inhibitor could be used. Cut to the Ottoman Empire, Dr. Ahmad Cesar did a wonderful trial of a drug called semiplimab. It also showed similar benefits like the pembrolizumab and nivolumab. Overall survival doubled. There was a small bit of problem with this drug. It worked, but it arrived late to a party that pembrolizumab and nivolumab had already owned. So by 2021, most oncologists had become comfortable with Pembro and Nivo. And as we become comfortable, habits get baked into guidelines, tumor boards, insurance firms, and nursing protocols. So semiplimab is good drug, but it was 7 years too late in the market. These two blokes at GeneTech, which was later purchased by Roche, discovered something called MPD-L32A0. IMPAR, the immunotherapy plus MPAR, Roche branding theme for, and we all know what the drug is. What they did was they tried to occupy a space which was not there. They tried doing it with a bevacizumab combination. It also showed some benefit, but the problem is that longer follow-up showed attenuated benefit with loss of statistical significance, but it still doesn't invalidate the approval. So combination anti-PD-L1 chemoimmunotherapy, IMPAR 130 for non-squamous cell carcinoma, atezoli and carbonap-pac showed a modest benefit when compared to the Pembro and the Nivos, but the ITT benefit was there regardless of PM1. Then they wanted to push bevacizumab into the picture. So atezolizumab plus bevacizumab plus carbo and paclitaxel, I still think it's very toxic, but they showed a median OS of 19.5 versus 14.7 months. The special benefits of populations were the ones with liver metastasis, probably because of the BEV component, and there was a dramatic benefit. Even there is an option, it gives us an option when EGFR and ELK progress. So this is single agent immune checkpoint inhibitors in short. It's summarized. It works when TPS is greater than 50% or PDL1 is on the higher side. Now, we cannot stop with just PDL1 or TMB1. There is a mixed data of further mutations like STK11 and KEAP. I have simplified it in the next thing. KRAS and STK11 co-mutations, there's a primary resistance to PD1 inhibitors with an overall response rate of less than the standard ones. When there's a co-mutation of KRAS and KEP, there's a paradoxically high TMB, yet resistant. Triple mutations, KRAS, STK11, KEP are extremely poor to treat. And there's some new evidence which says that CTLA4 blockade overcomes this resistance, recently published in Nature, and dual checkpoint inhibitors have a role there. Now, Poseidon and Triton trials I'll visit. So because of these mutations and new discoveries, the role of dual checkpoint blockade is becoming increasingly more relevant. We know it takes two to tango, like Sehwag and Tendulkar, Kohli and Rohit Sharma and Jay and Viru from the movie Sholay. So chemo IO combination therapy in first line setting, the trials which evaluated were Keynote 189, IMPAR 130, 150, Keynote 407. So they did a PD-L1 selected. Squamous was in Keynote 407, others were non-squamous. They showed a good benefit, a good reasonable benefit. So they approved FDA approval for wild type population, that is non-EGFR and ALK alteration. Keynote 189 made this the standard of care in PDL1 less than 50%. This was the landmark trial, and we still follow it in clinics partly. Pembrolizumab plus platinum plus pemetrexate is the go-to drug, if obviously a patient can afford it. And the benefit was across all subgroups, and this is a category 1 recommendation. IMPAR 150 of discussed. So the first line immunotherapy in squamous is something I would want to emphasize on. Squamous is destiny's forgotten child, if I may address it that way. Keynote 407 used immune checkpoint inhibitors, and it showed a modest advantage. The 5-year OS nearly doubled. The benefit was not as good as the non-squamous ones, but it's still there. So key findings, this is the first major advance for squamous cell in over a decade, and benefit was regardless of PD-L1 status. Biomarkers, the most important ones are a PD-L1 TPS greater than 50% or a higher tumor mutation burden. Selectivity is increased with PD-L1 expressions or TMB levels. This is the slide where I want to emphasize that if at all a tumor is EGFR mutated or there are driver mutations like the EGFR1, the benefit of immune checkpoint inhibitors is not that much, except for probably in second or third line. Where does Nivo-EP combination fit into current NCLC paradigm? Two trials which evaluated were Checkmate 227 and Checkmate 9A. Checkmate 227 showed that in first-line metastatic NSCLC, chemo-free Nivo plus EP beat platinum doublet for overall survival regardless of PD-L1 levels. This is surprising. And recently, a 6 years follow-up showed dual IO benefit even in PD-L1s as low as 1%. The 6-year OS was 22% versus 13%. Checkmate 9LA similarly showed that in first-line metastatic NSCLC, Nivo plus EP, only 2 cycles of chemotherapy, not full chemo, significantly prolonged overall survival versus the standard 4 cycles of chemo. Consistent benefit regarding of the bad markers, STK11, KEAP11, KRAS or TP53 mutations. And no consistent correlation between OS and Nivo EP versus chemo was seen by either PD-L1 or TMB alone. This is the graph at the end shows that very clearly. So to conclude, the dual immune checkpoint inhibitors, Nivo plus EP, improves overall survival versus chemotherapy in first-line metastatic, irrespective of PD-L1. The benefit is even seen in PD-L1 0. TMB also fails to clearly responders. The criticism was that these trials had too complex of an architecture to reach a very valid guideline incorporating conclusion. There were multiple cohorts. PD-L1 was stratified in every which way possible, evolving hierarchy of endpoints, and the control arms were platinum doublets without addition of immune checkpoint inhibitors. There was biological heterogeneity, and the applicability in 2025 practice is constrained for that reason alone. This is the Greek god of sea's fury with his trident, Poseidon. So when we have used 2, why not 3? Greed, for a want of a better word, is good. So we used first line Durva plus Tremi plus chemotherapy, and frankly speaking, I am a bit scared to do all that because of toxicity. But the median overall survival was a tad higher than what it would have been otherwise, 14.0 versus 11.7, and 5-year OS doubled. There was a benefit in hard to treat population, and the benefit was more. Even in PD-L1s less than 1%, the OS was benefit. STK, KEAP, KRAS, the difficult to treat mutations did well. When we were getting trained, like in early 2000s and all, so NHS was the thing. Everyone wanted to hear the opinion from across the pond. But I think in current day and age, their research is dead. And the opinion that matters is now from across the wall. The checkpoint blockade used to be a 3-player game. US, I use the word oops because they've let others develop the drugs and their companies have bought those products. Basically, the work was done in Japan and UA, and Beijing is now at the table. So a few honorable mentions. Rationale 304 is a Chinese anti-PD-1 in non-squamous. Camrelizumab, the trials are successful. They are showing good results in both histologies. And there's a GEMSTOR trial. The 4-year landmark data is there. I've not mentioned it for want of time. We cannot skip what happened in Berlin 2025. So there was a Harmony 6 trial presented there. Ivonescimab, my previous speaker has described the drug. It was simultaneously published in Lancet also. The study design was simple. It has shown a median PFS benefit of almost like this clinically meaningful benefit, but I would want to sleep over this data, see how it matures before I prescribe it to anyone. Pauline trial was there, chemo IO versus IO monotherapy. It has established our age-old notion that monotherapy is valid even today for PD-L1 greater than 50%. And we we can actually think of de-escalation in certain ways. There is additional data coming, and with new novel drugs like telluride 005, and the overall response rates are being talked, but it's just phase 2 data and too early days. So I would like to summarize my talk. For PDL1 high disease, give immunotherapy alone. PDL1 negative, try a combination, and something in between. You can try a immune checkpoint inhibitor and try avoiding the immunotherapy toxicity upfront. The only issue is if there is a KRAS mutation, STK11, or some mets here and there, like in difficult to treat sites like lung, or probably the disease burden is too high, you need rapid reduction, you need to add a chemotherapy. So we owe two things to our patients: honesty about our limits and stubborn refusal as physicians to accept those limits as final. And but a man's got to know his limits, and we all need to raise one to the translational scientists who work for decades in their labs and give us the wonderful drugs they have. And thank you very much. I am fearlessly yours, Rajan Yadav.
Thank you, Dr. Rajan. I enjoyed your slide. Similar topic I also talked in a very different forum. But
Yes, sir.
Full of waterfalls and full of plots and full of disease. We was a very colorful slides, right from Taliban to all kind of very colorful presentations. I enjoyed it.
Thank you so much, sir.
Thank you so much for your nice elucidation of role of immunotherapy in non-oncogenic. Hopefully, we are seeing more and more cases of non-oncogenic cases as the incidence of lung cancer is on the rise. Thank you so much.
Thank you so much, sir. Hope to see you in Madurai soon, sir.
Roshni, we have overshot the program by 30 minutes, but really I hope the program was very useful for the audience. And over to Roshni for winding up.
Thank you, sir. So thank you to all our distinguished speakers for the valuable time and insights. On behalf of IAIO, we extend our heartfelt thanks to Dr. Rajkumar Ramaswamy, sir, for leading today's program, and to all our expert speakers for their enriching contribution. We also thank all the participants for joining us today. We look forward to your presence in our upcoming IAIO Expert Insight sessions. Wishing everyone a pleasant evening. Thank you.
Thank you and good night.
Thank you, sir. Good night.